Hey everybody. Today we are going to cover Chapter 8, which is venipuncture procedures. The objectives are for you to demonstrate knowledge of each venipuncture step from the time the test request is received until the specimen is delivered to the lab, and define associated terminology. Number 2, describe how to perform a venipuncture using an evacuated tube system, a syringe, or a butterfly needle. List the required patient and specimen identification information. Describe how to handle patient ID discrepancies, and state the acceptable reasons for inability to collect a specimen. Number 3, identify challenges and unique aspects associated with collecting specimens from pediatric and geriatric patients. Number 4, describe why a patient would require dialysis and how it is performed, and exhibit an awareness of the type of care provided for long-term care, home care, and hospice patients. The overview of venipuncture. We already know that the process of venipuncture is collecting or drawing blood from a vein. So what we are going to cover in this chapter is how to correctly identify all different types of patients, how to safely obtain high-quality blood specimens, the actual venipuncture procedure itself. We are going to talk about the entire procedure here so that when I see you and we do the procedure, you know all the steps. We are also going to talk about challenges and issues that come up with pediatric patients, geriatric, those that are on dialysis, or long-term care or home care or hospice patients. So first, we are going to discuss patient registration. A patient must be registered with the healthcare facility or specimen collection center before specimen collection can take place. During this process, data is collected. It creates a patient record, and then that is for that person who is being admitted to the facility or has arrived for testing at the specimen collection center. Like, say they're going to have just an outpatient procedure and they're coming to get blood work, and then they're not having that done that day. The patient's identity, which includes their full name, their date of birth, their sex, their address, and proof of ID, is established, and the information is entered into the facility database or verified if the patient is already on the database. This usually involves a patient-specific identifier, which will appear on all test requests and specimen labels for that patient. Okay, the request for testing. Typically, a doctor or other qualified healthcare professional is who requests this lab testing. Exceptions are certain rapid tests that can be purchased and performed at home by consumers, and blood specimens requested by law enforcement used for evidence. Some states have legalized DAT, which is direct access testing, where the patients can order some of their own blood tests. So far, DAT is not widespread, and the number of tests that can be requested is very limited. Okay, the requisition. The test requisition, often referred to as a test rec or a lab order, is a laboratory form used by healthcare providers to request or order lab testing for these patients. They become part of the patient's medical record. They can be manual requisitions, as you see here in Figure 8.1, which is like a piece of paper, but those are declining with the use of computer systems. No one hardly has those anymore. Or they could be computer-generated requisitions, which are typically, they have the labels with them. That's like in 8.2. It is a requisition with a one-dimensional barcode. Or the last one there is barcode requisitions. So those are actually like the sticker requisitions. They're used with manual or computer-generated requisitions, where in some hospitals you scan the barcode of that label at the patient's bedside when you draw their blood. Okay, so let's discuss the venipuncture steps in an overview. You're going to first receive, review, and look at that accession test request. Then when you get it, you're going to decide in your mind what blood specimen tubes that you're going to need. And you're going to first go look at the patient to see how you're going to stick them. Like, does this patient have good veins? Do I need a ETS tube, or do I need a syringe, or do I need a butterfly, or can I use a 21 or 22, which is the bigger gauge needle? So you decide that when you get to the patient's bedside. But before you get to the patient's bedside, you are looking at these requisitions and you're deciding what color tubes you need. So when you get there, you're going to approach, greet, and identify your patient. You're going to explain the procedure and obtain their consent. You can do the verbal consent. Let them know what you want to do and get their consent. Then you're going to verify the collection requirements and identify any sensitivities or problems. You're going to sanitize your hands, put on gloves, position the patient, apply the tourniquet, ask the patient to make a fist. Remember, we do not pump the fist. Pumping the fist can increase certain analytes like potassium in the blood, which can interfere with their results being processed in the lab. So don't pump the fist, just make a fist. You're going to select a vein, release the tourniquet, ask the patient to open the fist. Then you're going to clean and air dry the site, prepare your collection equipment, reapply the tourniquet, because remember, it can't be on the arm for longer than 1 minute. So you put it on for the minute that you were looking. You decided where you're going to stick them at. You take it off, you clean it, let it air dry, then you put it back on. You uncap and inspect the needle like you're looking for any burrs or anything that's wrong with the needle. Ask the patient to remake a fist, anchor the vein, and insert the needle. You're going to establish blood flow. Once blood flow gets established and you are on your last tube, if you're using the evacuated tube system, then you can release the tourniquet. Make sure you do that step before you take out the needle. Release the tourniquet. Ask the patient to open their fist. Fill and remove the tubes in the order of draw, or fill the syringe. Okay, releasing the tourniquet once you establish blood flow. If their blood flow, there's kind of a discrepancy in between 12 and 13, because if the blood flow is not going very fast or they don't have a great vein, then I would not release that tourniquet before I got all of my tubes collected. Okay, so between 12 and 13, if the blood, this is what I would do. If you have the tourniquet on and it has not been longer than a minute, okay, when we've started, then you're going to fill the tubes in order, in the order of draw. And then when you get to the last tube, then pop the tourniquet at that time. But if you've had that tourniquet on them for a long time, then yes, then you need to do it in that order, okay? Because then you've had that tourniquet on so long that then the specimen is going to be, there's going to be a problem with the specimen like hemoconcentration. So after the tourniquet is off and you've gotten all your blood, withdraw the needle, place the gauze, activate the needle safety features, and apply pressure. If you have the ETS system, you're going to discard the blood collection unit in the sharps container immediately. That's the whole thing. If it is a syringe system, you discard the needle in the sharps, but then you're still going to need the blood that is in the actual syringe. Attach a transfer device. You're going to transfer the blood and then discard the syringe and the transfer device in the sharps. So it depends on whether you use a syringe or an ETS. Label and prepare the tubes right there at the patient's side for handling and transport. Check the patient's arm, make sure they're not still bleeding, and apply a bandage. Dispose of used materials and reposition the moved items. Put everything back. Thank the patient, remove your gloves, sanitize your hands, and take the specimens to the lab. Okay, now this is the steps in a slower order. Step 1 of the venipuncture: receive, review, and accession the test request, okay? Receive the test request, review the requisition. That means checking to see that all the required info is present and complete on that requisition. Make certain the request matches the labels that you have. Remember, the labels are going to either go with the paper system or the barcoded system. Resolve any problems or discrepancies with the provider. The provider would be the doctor or the nurse practitioner, whoever ordered the test. Verify the test to be collected and the time and date of collection, because some tests need to be in the morning, some need to be at night, some need to be postprandial, which means 2 hours after the patient has ate a meal. So, you need to verify all of that. Identify diet restrictions or other special circumstances. Determine test status and collection priority, because stats go first, then ASAPs, and then routines. Okay, so if you've got a pile of routines to do and one stat, then you're going to need to pick that stat and go do it first. And then you're going to accession the test request. Okay, this is a picture of a manual requisition. So you're going to see with any type of requisition, it is essential for the information to be transcribed or entered correctly. So all of this must match what you have on the barcodes. This is a computer requisition. So you've got this generated barcode, and really and truly this one you just scan it in and it should match up. The phlebotomist is typically required to write the time of collection and your initials on the label after collecting the specimen. That is still true. When you draw a sample, you then do the time. I typically do both, the date, time, and your initials on that barcode. Okay, step number 2, approach, greet, and identify the patient. So if you are in a hospital setting, then you're going to look for signs containing the patient info. For example, if they are a DNR, do not resuscitate. In your book, there is a page I want you to look at. Let me find it on here. Okay, on page 259, it shows you figure 8.4. I want you to look at that one. That shows you no blood pressure or venipuncture, like it'll say which arm, the right arm or the left arm. But also the other 2 signs that are not in this PowerPoint that I want you to be aware of. Look at that picture in figure 8.4 on page 259, figure B. Okay, figure B is a fall colored leaf. That is symbolizing a fall precaution. Some hospitals just literally have fall precaution labels, or, it says that, or either it is an armband on the patient, but some do have this leaf and it symbolizes a fall. And then C on there is a falling leaf with a teardrop symbolizing the loss of a newborn. So those are just 2 other signs besides this one that it shows in your PowerPoint that I wanted you to be aware of. DNR, you need to know that that means do not resuscitate. DNAR means do not attempt resuscitation. Okay, so those are 2 things. When you're entering a patient's room, you're going to knock very lightly. You don't want to scare a patient. Make your presence known, like knock, knock. This is Shannon from the lab. Can I come in? Because you don't want to catch anybody undressing or in a compromising position as you're going into their room. Don't just barge in. So you knock lightly, make your presence known, and respect their privacy. They will usually always say, come on in. Scan the room for sharps containers. You need to know where the sharps are because you're going to have needles you got to throw away. Any obstacles, make sure you're not going to be caught up in any wires or anything over there by their bedside or IVs. Don't interrupt physicians and clergy. If physicians or clergy are in the room and you need to draw blood, then you can go on in and draw that blood, but don't interrupt the physicians and clergy if it is not necessary, okay? Ask family and visitors to step out, but use your discretion when following facility protocol if they wish to stay. Document if the patient is unavailable, like if you went by the room and they weren't there, then document that so it doesn't look like you just skipped it and you're going to have to go back. Use bedside manner to gain the patient's trust and confidence to put them at ease. If you greet the patient, you're going to verify their name and their date of birth. Check the ID band for an inpatient. If it's an outpatient, they still usually have the ID band. Be aware of bans from other facilities or for other purposes. Like if they got transferred in, make sure you're not matching it up with a barcode that they have on, a band they have maybe from another hospital and you just didn't realize they haven't cut it off yet. Use three-way ID. This means patient's verbal ID statements, the ID band, and visual comparison of the label with the ID band. This means, can you say your name? Can you tell me your name, first and last name? Have them spell it if it's something different. Then you check their ID band and you visually look at whether that matches up. Also be aware of ID situations that require extra care. For example, common names. Like if you have a John Smith, be extra careful that you're checking their med rec numbers, you're checking something else, their date of birth. You are being extra careful with that because there may be another John Smith down the hall in the same hospital. Okay, so if it is a common name, be extremely careful. Notify the nurse of the patient of any ID discrepancies that you find. Don't draw their blood, just say, I need to talk to your nurse, I will be back. If they're missing an ID, check their ankle. Make sure that they don't have one there. Avoid using bands found elsewhere in the room. If they have a band on the bed, you can't count that, okay? Because that may mean that was a different patient and they haven't cut it off the bed yet, but they cleaned it and put a new patient in that bed. So if it is not physically on the patient, you can't count it. And follow institutional protocol for anything else that they have. If they are sleeping, you cannot stick a sleeping patient, so wake them gently to obtain identification and consent. Ask a relative or nurse to identify an unconscious patient. Be aware that they may hear you and they may feel pain, so you still talk to them like they can hear everything that you say, but you get someone else to identify them that is in the room. Say, can you tell me who this patient is? And then identify them by their armband as well. If you have an unidentified emergency room patient, then you are going to follow the CSLI standards and AABI guidelines. And you have a chart, let's see. Okay, it's not a chart, but on page 263 in your textbook, figure 8-7, I do want to show you this. This is an example of a special 3-part ID band used for unidentified emergency room patients. Okay, you see how it doesn't have the name? We don't know the name yet, but at least it gives you numbers to match up with your requisition, because that patient, when they come in, they're still going to be assigned a temporary ID number. Okay, so once they find out who the patient is, then they can change that up and add the patient's name and so on. But this temporary label number should match up to your labels that you have. And then when they get a permanent number, you can cross-reference it with the temporary number and still make sure that all of those results go across as the same patient. Okay, so that one's a little more complicated. Identification of young, mentally incompetent, or non-English speaking patients can be aided by friends, relatives, or HCW means healthcare workers. Neonates and infants, they're going to have ID bands usually on their lower leg. Okay, for you, it's still going to be a band. You're still going to use it. Outpatient IDs, they may have an ID card sometimes rather than a band, but they should be holding it. Okay, step 3, explain the procedure and obtain consent. You're going to address the patient's inquiries, like anything that they may have a question about, handle any patient objections. You are going to address difficult patients. You know, if you have a difficult patient, sometimes they may be stressed out, they may be lonely, they may be scared, they may be just plain disagreeable, because it happens. It's important for you to remain calm and professional in this situation and treat the patient in a very caring manner, no matter how that patient is responding. The patient is usually reacting to the fact that they have loss of control. They are being hospitalized, they're nervous, and it's not personally against you. They just don't know what to do. They feel out of control. So this patient may object to being tested at first, but if you explain to them that this is what the doctor needs to be able to treat them, usually they'll come around. You know, and if you give them the chance to take control, like you're not going to stick them without their permission. Okay, so if you remind them that they do have the right to refuse testing, but if they do, then the doctor can't get the valid results. Okay, so that's kind of how you do that. If you have a cognitively impaired or combative patient, usually that involves they have trouble learning, remembering, or even like making decisions. It could be caused by many different things. Something like depression, even medication side effects, or dementia. They may be unpredictable or have sudden movements that could pose a danger to themselves. It could also pose a danger to you as a phlebotomist. They may not understand you when you attempt to explain why you're there. If so, consent for those procedures may need to be obtained from a guardian of this patient. You may also need to enlist the help of one of the patient's caregivers to assist you during the blood draw, like maybe their nurse. You also want to make certain you have an unobstructed exit route in case it is needed. Be mindful of where you place equipment. Keep it out of reach of the patient. When venipuncture on every patient, always have a gauze pad ready, but also be prepared to release the tourniquet quickly in case the patient pulls the needle out or suddenly jerks, causing it to bleed out. If the needle penetrates deep in the arm, inform the patient's nurse or other healthcare provider and document the incident according to the facility protocol, like if anything happened. Never position yourself in such a way that a potentially combative patient is between you and the only exit in that room, okay? Handling patients in altered mental states. It could be an altered state of consciousness or a state of mind that is altered. Either way, those are significantly different. A mental state is a state that's very different from the normal waking state of a conscious person, okay? This means they have changes in brain function, such as confusion, disorientation, memory loss, things like that. Abnormal behaviors like emotional outburst. Patients who may undergo a change in mental status can include patients like transplant patients, patients with liver failure, and those suffering from post-traumatic stress syndrome. Alcohol abuse, illegal drugs, marijuana, even certain prescription drugs can also be associated with mental problems in patients. Such conditions can cause these patients problems with their blood collection because you're going to have problems verifying the identity of the patient, explaining the procedure, and obtaining informed consent. So consent for specimen collection in this case may need to be obtained again from the authorized relative or guardian of that patient. In addition, patients who have drug addictions can have scarring of the skin and veins that makes finding and palpating their veins difficult. So assistance with these patients is required for the safety of everybody involved. Others nearby, also could be at risk. In addition, certain liabilities may be associated with dealing with these kind of patients. So you're going to consult the facility protocol for guidance. Like the facility protocol is whatever your hospital states. Okay, lastly there, address needle phobia. If they have an admission, like they say they have needle phobia, this is an intense fear of needles, okay? So they may suggest it, they may tell you whatever it is, it should not be taken lightly. Needle phobic patients typically have a heightened sensitivity to pain, and they can experience a shock type reaction during or immediately following venipuncture. Symptoms can include very paleness, profuse sweating, lightheadedness, nausea, and they can even faint. In severe cases, they have even been known to suffer from an arrhythmia and go into cardiac arrest, but that is very rare. So a persistent fear of those pins and needles, just make sure that you take that seriously if a patient says that, and not if they're just saying, oh, I'm just kidding. About 10% of the population does have this condition. So if this happens to you, if you know ahead of time that an outpatient is needle phobic, and you're the experienced person who's going to do the draw, do not heighten the patient's anxiety by keeping them waiting any longer than necessary, like if you know they're out there. Obtain this consent, but do not go into detail explaining every aspect because they're already scared. They already know. Perform the draw quickly and efficiently. When it's over, keep the patient lying down until you are certain they are calm and not about to faint when they get up and leave. It's recommended that anyone who has suffered a severe reaction from needle phobia, make sure that whoever is taking care of them, that you have somebody that for sure knows CPR, which if you're in the healthcare setting you will, and that there is a defibrillator ready just in case, like one that is accessible. Okay, step 4, verify the collection requirements, sensitivities, and problems. So let's verify some diet restrictions here. Eating can alter blood composition. So any kind of diet restrictions that your patient has, like if they were supposed to be fasting, this means refraining from eating for a certain amount of time, then make sure that you ask your patient, when was the last time that you ate? Okay, if there are no other, like what if there's a restriction like NPO? That means nothing for surgery, okay? That's usually the patient may have water during their fasting period, and that's pretty much it. So ask them. Address any sensitivities. This means items like your gloves and tourniquets. Used to, they were made of latex. Now they're pretty much latex free. But if latex is anywhere in there, you must ask your patients if they're allergic to latex, because exposure to latex can trigger life-threatening reactions in those who are hypersensitive. But usually, these patients know this and they will automatically tell you that. Some patients have sensitivities or allergies to the adhesive in Band-Aids or antiseptics like iodine. So you got to have alternatives available for them. So you don't put a Band-Aid on them, you use Coban. What if they are allergic to iodine? Then you only use the alcohol pad, okay? Identify previous problems. Ask your patient if they've had any problems with previous blood draws, if they fainted. If they fainted, then you need to have them lie down. So, like if they tell you that anything went wrong before, you need to make sure. One other thing is an outpatient might have tell you they have significant bruising the last time they had a blood draw. Well, they may require extra time holding pressure before you let them go. It's a possibility it is a patient that is on blood thinners. Okay, address objects in the patient's mouth. Do not allow a patient to eat, drink, chew gum, or have a thermometer, toothpick, or anything in their mouth during a blood collection. Okay? Objects in the mouth can cause choking. A bite reflex could break a thermometer, injure a patient. So politely ask the patient to stop eating or drinking and remove objects from their mouth until you're finished with the venipuncture. Step 5, sanitize your hands and put on gloves. Remember, if your hands have anything visible on them, we wash them with soap and water. If not, you can use a sanitizer, an alcohol-based hand sanitizer. Step 6, position your patient, apply the tourniquet, ask the patient to make a fist. Make sure their hand is well supported. Avoid bending at the elbow for AC procedures. Seated patients, typically those are your outpatients. Recumbent patients, those are the ones laying back. Those are typically your inpatients. Apply the tourniquet snugly, 3 to 4 inches above the intended site, assuring the ends or tails are above the AC area. Remember, they point up. Never apply over an open sore. Apply over a dry washcloth or gauze. If your patient has very sensitive skin, you can put it over like a little dry washcloth there. Ask the patient to make a fist, but no pumping the fist. A tourniquet has a greater tendency to roll or twist on the arms of obese patients, so they do have bariatric tourniquets available from certain manufacturers. However, if you don't have one, 2 tourniquets placed on top of each other and used together can sometimes be sturdy enough to prevent it from rolling. Step 7, select the vein, release the tourniquet, ask the patient to open the fist. The preferred site is the AC, antecubital area. First choices are median cubital, median veins. Palpate your patient's dominant arm with the index finger. Roll your finger side to side while pressing against the vein to judge its size, whether it is big or little bitty. Avoid veins that feel hard or cord-like or lack resilience. Release the tourniquet and have the patient open the fist. Step 8, clean the site with an antiseptic like 70% isopropyl alcohol to avoid infection or contamination. You may clean using a circular motion, moving outward and widening concentric circles starting right in the middle for an area 2 to 3 inches in diameter. Allow the area to air dry. Remember, don't fan it, don't blow it, don't wipe it. 30 seconds to 1 minute. Do not retouch the site after cleaning, so don't palpate them again. But if necessary, you can clean it and air dry it again if you do happen to touch it and forget. Or you want to touch it because you don't really know where you're going to go, but you have to clean it again if you do. A little hint is wherever you find the vein you want to stick, leave the alcohol pad pointing in the direction of the vein. It kind of gives you a mental check. Oh, I want to stick right above the point of where this alcohol pad is pointing. Step 9, prepare your collection equipment. If you are using ETS equipment, you need to get that all together because an ETS equipment is going to be the ETS needle. Remember, that is the double-sided needle and a tube holder. You're going to inspect the seal of the needle. If it is broken, discard the needle because it's no longer sterile. Select a new one. Twist off the back cover of the ETS needle to expose the short or the back end of the needle that is covered by a retractable sleeve. Screw this end of the needle into the threaded hub of an ETS tube holder. Do not yet remove the needle sheath, which is the cap or the cover. Select the appropriate ETS tubes. Check the expiration date on each one to make certain it has not expired. Discard any tube that is expired. Tap additive tubes lightly to dislodge any additive that may be adhering to the tube stopper and arrange them in the order of draw, like literally lay them out in the order of draw. Place the first tube in the holder and use a slight clockwise twist to push it onto the needle just far enough to secure it. Don't push it all the way on, but just enough to secure it. and keep it from falling out, but not far enough to release the tube vacuum. Okay, the blood collection set preparation. This is checking your needles. What size do we want to use? They're available in various gauges. You've got a 23 gauge blood collection set. This would be like your butterfly or wing set. That's commonly used for small and difficult veins. One type has a hub that can be attached to a syringe, and the other type has a hub with a multi-sample adapter that can be threaded onto an ETS tube holder. The adapter can specifically be removed to also allow the needle to be just used with a syringe, okay, in that case. Either way, whatever you're doing is you're making sure you're picking the right one. Okay, select equipment preparation. This is meaning if we are not going to use a butterfly there, make sure you pick the right other size of needle. If you are going to do maybe a syringe and needle instead of the butterfly and a syringe, if you're just using a regular needle, you're going to make sure that you pick the correct size. Position your equipment for use. This just means placing those supplies like gauze and alcohol pads. Place all that within easy reach out of your cart. They're usually placed on the same side of the patient's arm as your free or non-dominant hand during the venipuncture. This way you will not have to cross over the venipuncture arm to reach them. Crossing over can lead to safety issues like bumping your other arm on the patient's arm during venipuncture or moving or dislodging the needle. So you want to make sure that it's all right there handy. Do not place your phlebotomy tray on the patient's bed or any other place that could be contaminated by it. If you set it on the patient's bedside table, place it on a clean paper towel, okay, before you do that. Okay, reapply the tourniquet. Uncap and inspect your needle. Be careful not to touch your cleaned area that you've already cleaned. Okay, so when a tourniquet has been in place for longer than 1 minute, it should be released and reapplied after 2 minutes. So if it's been on 1 minute, you got to wait 2 minutes to put it back on. Okay, ask the patient to remake a fist. Anchor the vein and insert the needle. When you are anchoring the vein, you are using your non-dominant hand, not the one that has the needle and syringe, the other one, to secure the vein down firmly. Put your thumb at least 1 to 2 inches below and slightly to the side of the site. This means you're trying to hold it tight down. Pull the skin toward the wrist. Never place your fingers above the puncture site because you don't want to mess with the needle and then stick your own self. Hold the collection device or butterfly needle in your dominant hand with the bevel facing up. Position the needle above the insertion site. Insert at a 30-degree angle or less in smooth, steady forward motion. Rest your fingers on your patient's arm, the two underneath the hub. That is an illustration of what 30 degrees would look like. Establish blood flow. Release the tourniquet. Ask the patient to open their fist. So you're going to advance your collection tube, that first one, into the tube holder until the stopper is completely penetrated by the needle. Push the tube with your thumb while your index and middle fingers straddle and grasp the phalanges of the tube holder, pulling back slightly. Blood will begin to flow into the tube, if you're in the vein, that is. Release the tourniquet, have the patient release their fist. Fill all the tubes, remove and mix the tubes in the order of draw, or fill the syringe if you are using a syringe. Place the gauze over and just to the side of the needle. Then you withdraw the needle. Immediately slide the gauze over the puncture site when the needle comes out. Apply pressure with your non-dominant hand while activating the safety feature. If it is an ETS, you're going to discard the whole unit in the sharps. If it is the syringe system, you're going to discard, you're going to unscrew. You're going to have the safety needle, the safety over the needle so there's no risk to be stuck. But you're going to unscrew that, just the needle, and you're going to attach a transfer device. You're going to transfer blood. First, you're going to throw away that needle that you took off. Transfer blood and discard, after you finish transferring the blood, then discard that whole thing, the syringe and the transfer device, into the sharps. Okay, we got our tubes now. You're going to label these at the patient's bedside. Patient's first and last names, they should be on there. The patient's identification number or date of birth, the date and time of collection, that is what you write on there. The phlebotomist initials or code. Any additional information such as fasting. You're going to compare this information on each labeled tube with the patient's wristband and the requisition. Check your patient's arm. If it stopped bleeding, apply the bandage. Dispose of all the rest use materials like your other garbage that just does not go in the sharps container, and reposition moved items, like if you scooted anything out of the way, scoot it back. Thank your patient, remove your gloves, sanitize your hands, and then take the specimens to the lab. Pediatric venipunctures. The challenges are the small, undeveloped veins. I think there is just a second, let me check this book for something that I was going to show you. Okay, on page 303 in your textbook, there is table 8.2. You do not have to memorize this, but I do want you to see it. It gives you the ages of the patient with a disease or a condition. It also tells you the maximum total blood volume, like the blood draw, the maximum that you can draw per day per kilogram of body weight. Okay, because you just can't draw tons of blood, especially on babies. So there's only so much you can get out of them in a day. So when you're collecting blood by venipuncture from infants and children, if they require a lot of blood and tests that can't normally be performed by skin puncture, they're going to have a venipuncture done. Okay, so venipuncture in kids under the age of 2 should be limited to superficial veins and not deep, hard to find veins. Normally, the most accessible veins of infants and toddlers are the veins of the AC fossa and the forearm. Other potential venipuncture sites include the medial backside of the wrist, the dorsum of the foot, the scalp, and the medial ankle. Venipuncture of these alternate sites, however, requires special training and the permission of the patient's physician. Okay, so in that case, you would need special permission to do this. Okay, capillary collection is normally recommended for pediatric patients because you don't want to draw a lot of blood out of them, especially newborns and infants up to 12 months. Their veins are small, not well developed. You may even permanently damage them. However, sometimes capillary is not feasible or possible to the type of, like the volume of tests they've ordered. If that venipuncture is necessary on pediatric patients, you still got to have some skill and you're going to need some help in holding them. So, children under 2, limit it to superficial veins. Also, make sure you use a 25 or 23 gauge if you don't have a 25 gauge butterfly. That is the smallest needle. Smaller blood volumes in the body. This is why we do not want to draw this too much from those babies. What if we're dealing with parents or guardians of these? Well, first of all, you're not going to get that kid's permission because they don't have the permission to give you. You got to get this from the parent or guardian. So you've got to be nice to that parent or guardian. So you're going to earn their trust by being warm, friendly, calm, and confident, caring to them. Ask about the child's past experiences, if they've had any blood drawn, and you allow them to stay in the room, okay? You don't ask them to walk out because, in fact, they may keep the child much calmer than you would. Okay, involvement of the child life specialist. Um, with the creation of children's hospitals and specialized children's services, a lot of healthcare programs that have a large pediatric population, they are using child life specialists. Um, this is a They help children and their families cope with illnesses and challenges by hospitalizations and procedures, including blood draws. So, in ideal circumstances, trusting relationships with children can be created and maintained by this child life specialist who can facilitate blood draws to be less traumatic. While not all centers employ them, their services should be considered whenever appropriate. They basically try to entertain that child or help with pain interventions, okay, to help this child not be so upset. So let's talk about EMLA, which is eutectic mixture of local anesthetics. This is a topical anesthetic that contains lidocaine and pre-lidocaine. It's available in a cream that must be covered with a clear dressing or a patch after you apply it. It takes approximately 1 hour, that is the drawback. It takes an hour for it to anesthetize the area to a depth of about 5 millimeters. It can only be applied to intact skin, and it must be applied by a licensed healthcare practitioner following strict dosage, the amount of the area covered, and application times based on the child's age and weight to prevent toxicity from absorption through the skin. It cannot be used on patients who are allergic to local anesthetics, infants with a gestational age of less than 37 weeks, or infants under 12 months of age who are receiving treatment with methemoglobin inducing agents. Okay? Or oral sucrose. Let's talk about that. The use of 12 to 24% solution of oral sucrose has been shown to reduce the pain of procedures like heel puncture or venipuncture in infants up to 6 months of age. A 24% solution of sucrose, which is prepared by mixing 4 teaspoons of water with 1 teaspoon of sugar, can be administered by dropper, nipple, or oral syringe or on a pacifier, provided it will not interfere with the test to be collected or diet restrictions. You also have sucrose nipples and pacifiers available commercially. This sucrose must be given to the infant 2 minutes before the procedure, and its pain relieving benefits last for about 5 minutes. Okay, so you got about 5 minutes after they get that. Studies have shown that infants given sucrose or even a regular pacifier just by itself cry for a shorter time and are more alert and less fussy after the procedure. Also on this slide you see here, never tell a child it won't hurt. Instead, say it may hurt just a little bit, but it'll be over quickly. Selecting a method of restraint. If it's an infant, you can wrap them up, swaddle them in a blanket. If it is a toddler, have the parent hold them on their lap. Have a second person, though, lean over the child who is laying down if you don't want to get them up out of the bed. Equipment selection. 23 gauge butterfly needles attached to an ETS or syringe. If they are very small, remember you can do 25 gauge butterflies. Collect the minimum amount of blood required. Don't collect anything extra. Geriatric patients. Challenges are skin changes, hearing impairment, visual impairment, mental impairment. Effects of diseases like arthritis, coagulation problems, diabetes, Parkinson's and strokes, and pulmonary function. Safety issues are more space is needed for wheelchairs and walkers, non-slip and clutter-free floors. Patients in wheelchairs, you want to lock their wheels when drawing blood or assisting them from their chair. If you are drawing a geriatric patient, you still have patient identification. But remember, we said they have hearing difficulties sometimes. Don't rely on nods of agreement. Verify patient information with a relative or attendant if you have to. The equipment selection: use butterfly needles or short draw tubes on them. Don't tie the tourniquet so hard that it damages their skin. Make it enough where you can see the vein good, but loose enough to not damage. Avoid any bruised areas when you are deciding where to stick them from previous punctures. Don't rub them too vigorously when you're cleaning the site. Their skin is thinner. Anchor the vein firmly to avoid rolling, because their veins do roll. Hold pressure longer, so it may take longer for their bleeding to stop. On dialysis patients, make sure you do not use the arm with the AV fistula for venipuncture. If they are long-term care patients, they may be in an adult daycare or assisted living, rehab, or a private home. If they are a home care patient and you are a phlebotomist, you must have exceptional phlebotomy, interpersonal, and organizational skills. You also, because you don't have any backup, it's just you if you're a home care phlebotomist. You must have the ability to function independently. You must have the ability to be comfortable working in varied and unusual circumstances because you're going to their home. You must also have the ability to carry all the equipment with you. If it is a hospice patient, this means that you have to require extra care, kindness, and respect on your part. The NACLS level competencies are some of the same as the beginning, so you don't have to go over those. As always, if you have questions, be sure and let me know. I'll see you next time.